with regards to the science, I mean, you're obviously very involved in academics in developing the field, especially considering, that you're still quite young and just becoming essentially a cardiac surgeon. But you've seen many of the novel, innovative aspects of cardiac surgery. And in your view, in your perspective, what are the challenges that are being faced by what we can offer to underserviced society populations, right, in Canada and globally? Like, are we mythed in thinking that, for instance, multivessel bypass surgery using arteriographs, sternotomy, etc., is well adapted to a population that may be 2,000-3,000 kilometers away, and that perhaps there are other approaches that may be more adapted to their need? Because we procedural people, I always repeat, we tend to focus maybe a little bit too much on believing that the procedure we offer is a solution for the patient, and sometimes it's not, right? There's many other dynamics that have to be considered. What are your thoughts around that?
Absolutely. So I remember you saying this at some point in residency, and I don't know if I'm getting the quote exactly right or paraphrasing, but when talking about, for example, revascularization and looking at CABG versus PCI, and talking about how we can improve not just, well, I guess CABG, but all coronary surgery, is make it safer and make it less invasive. And that absolutely applies for when you're treating patients, I think, that are very remote and far away. Because if we want to be able to get these patients in from the north, we have to ensure that we make this procedure as safe as possible, but giving them the best outcome possible, is the most durable outcome, so that they can have a smooth recovery and get back home easily. We're not worried about major issues or complications in follow-up, and make it less invasive, so the recovery is faster, so they're not stuck down south for weeks at a time, separated from their family, and they can get back home and get back to doing activities that they like. And so, I was very fortunate to train with you and Dr. Glenner, who do, minimally invasive coronary surgery. And that, I think, is an emerging field in revascularization surgery. How can we make it less invasive and give the patients great benefit of a, leaded LED graft? How can we train more surgeons to do multi-vessel small thoracotomy bypasses like you do? Because it's obviously possible and feasible. So if we have surgeons who can offer that, I think that's fantastic. And in terms of valvular heart disease, I mean, catheter-based approaches are kind of this new wave coming in. And so maybe that is a more attractive option for treating patients who live remotely, or you might not be able to follow up with, because it's a small groin incision or poke as opposed to a big sternotomy, and they're up and mobile a lot faster. So the new technologies, I think, are going to just be really beneficial for populations like mine, where my family's from.
Donna, this is great. Very important and valuable perspective. I'd like to finish with a last question relating your personal context and background and what you're doing now and your advanced studies, as to where you think you'll land, where the eagle will be landing in 5-10 years. And obviously right now you're doing kind of everything, right? You're very involved in clinical innovation, top-notch surgery, education, research at some point. And also you have a huge societal role that I certainly did not have when I was at your stage. And there's a whole nation that's looking at you, and you're on multiple forums across the country and likely beyond. Where is this going to decant itself? What do you want to do as a cardiovascular leader of tomorrow? Where do you see your focus and your biggest impact in 5 years? I realize that's a bit of a difficult question to answer now, but it must be one that you question yourself about often.
Oh, absolutely. So I kind of divided into two answers, or two things. I kind of have my clinical or operative focus, I'd say. and then my broader clinical focus. And so as a surgeon in the OR, I mean, I love coronary surgery. I really do envision myself being a coronary surgeon. And so I'd love to focus on that. And one focus I have here at the clinic is learning how to do myectomies, which is a really niche, very cool surgery. And I've been working more and more with the mitral valve surgeons. So I'm really starting to enjoy that. But really coronaries and myectomies, I think, will be my two strong niches. But in terms of broader kind of clinical goals or what I see myself doing is really focusing on cardiovascular health in women and Indigenous populations, because we know that we don't know enough about their health, and we know that or we do know at least though that outcomes are not as good in women and Indigenous populations when it comes to surgery, when it comes to heart failure, when it comes to heart attacks and just overall cardiovascular care. So given that I'm a woman and Indigenous, I feel like I can really relate to and understand those populations, and hopefully improve research and care equity to those populations.
And why is that, in your opinion? Is it that women are more stoic? Is it that there's less research and less applicability of the science to them? Is it because they're always spending their time helping others, perhaps more than their gender counterpart might be? That might be a bit stereotypical, or is it a combination of all of the above? And how does it relate to northern communities? How different would it be than it would be in southern Canada, for instance?
Well, you really hit kind of all the topics. It's really multifactorial. Surveys have been sent out and questionnaires asking women, well, why don't you seek care when you're experiencing chest pains or palpitations or what have you? And a lot of it has to deal with the pressures of taking care of the family, or women might experience symptoms differently than men, and what's stereotypically described as chest pain or heart attack pain or palpitations. So women kind of push it off thinking it's nothing. And also that women are completely under-researched compared to men. So we don't know how they do with, treatments that men do well with, because women just haven't been included in the studies as much. And so if you extrapolate that to families back home up north, I think there often can be even more emphasis on the mother, the matriarch that's really taking care of the family and really is the rock of the family. And, you can't necessarily separate her from the family for weeks at a time, or take one of the parents out of the picture where, they're not getting income for the time that they're in hospital down south for many weeks. So I think it just, up north, any difficulties that women experience, period, in Canada, or the inequities are just amplified up north.
Well, Donna, this was very fascinating. Thank you for your insights. It's very refreshing to me, and also extremely apposite, I think, to hear your thoughts, especially as the CCS, you may know, will be engaging in a more societal role pertaining to Canadian cardiovascular care disparities. So thank you for allowing us to exchange this evening. And thank you all for watching this podcast, whatever time of the day that you're watching it at. And Donna, our division, the Heart Institute, we're very proud of you. And I know the CCS is as well, and Canada is as well. And I hear more and more that the Cleveland Clinic is also. So congratulations, and keep on working hard like you do. And thanks for all you do.
Thank you so much. Thank you.
Thank you.